Got Kyle Kleiss coming online. We got Sheriff Big coming in. Chris, can you hear the ding dong bell when new people are coming in? Okay. Okay. So that's just a new feature that we have to admit people. So if we do have some late arrivals, we'll be able to kind of identify them, but admit them in. So.
And that's a feature I just turned on for this meeting. And I can show you how to do that for future meetings, just so there's that ringer there in case I miss somebody popping in or you miss somebody, that sound goes off.
Yeah, it's helpful. So thank you.
I wonder how that became the ding dong. I wonder how that became the sound for like a doorbell.
Interesting, because it is a universal sound.
It is. It does. And it is, what is that called? Is that onomatopoeia? When it sounds like it's...
Oh, when it sounds like
it's like
the
it's
word
spelled. Yeah.
Yeah.
Ding dong. Ding dong.
Wendy Winger.
Sounds like a question for Sheldon from the Big Bang Theory.
It does.
Oh, inquiring minds want to know here. And we got Santana as well.
Morning.
Morning.
So I think it must be noon. I can't tell what time it, or I mean 11 o'clock. I can't tell what time it is because that's covered up here somewhere. Here we go, 11:01. So I think we'll get started. Kara Helmer is going to join us any minute. And so I would ask that we kind of whatever, stop whatever we're doing and then have her, let her do her presentation so that we can get her back to making money for us by seeing people. I think we can see everybody on one screen here. It looks like we've got Sarah, me, we've got Heather, Jackie, Kevin, Kyle, Heidi, Sandy, Mary, Wendy, Santana, and then Krista hiding out there with her glam shot. She just looks so good in that picture. I mean, not that she doesn't look good in real life, but she looks really good in that picture. She says it's the filter, but
It
anyway.
is all filters.
All right. I would entertain a motion to approve the minutes of our August 25th meeting. Looks like Heather. Wendy, was that a second? Oh, okay. Was a second by Wendy. Any discussion? Otherwise, all those in, yeah?
I do have discussion on number 7, reentry update. It's incorrect. Number 6, veteran peer support collaboration. I talked about 2 things and they're kind of mixed together here. So the veteran position is just a special project. And it has 3 parts. One is like doing focus groups and then preparing a presentation for justice system partners specific to veterans issues. And so that's one part. And well, the focus group is a part, the presentations are a part, and then the developing a battle buddy program is a third part of it. And it's the battle buddies model, like we're not developing the program where it's going to be staffed. We're just developing a model and kind of getting it ready to pilot in that. So that I didn't want it to look like there's a So the 3-year grant project, that is the funding that I have that we're going to partner with Dunn County on for a certified reentry peer specialist. And if it helps anyone, I can write that more clearly and send that to them because I don't want to take time away from your meeting. But the way this reads, it's a little bit misleading or confusing.
Sure, Mary, if you would be willing to offer language that would clear up the minutes so that they accurately reflect what the projects entail, that would be great. And if so, I have a motion and a second to approve the minutes, and I would just ask if it's okay to amend that motion to reflect with Mary's new updated language. If that is an acceptable alternative, then I would, all those in favor of approving those minutes signify by saying aye.
Bye.
Aye.
Aye.
All right, a few random ayes and some ayes. All right, so I saw that Kara popped on. And so we have invited, you recall from our last month, we talked a little bit about medication assisted treatment and about, well, 2 summers ago, the state offered up some money by way of a grant to have counties implement MAT in jail. And I asked for follow-up on that. Actually, 16 counties in Wisconsin received funding to be able to do that, including some big counties like Rock County and Dane County, but also some little tiny counties like Bayfield County. So anyway, but I think last month we talked about just giving everyone a core level of understanding about what medication assisted treatment is. And Kara is a nurse prescriber who works for us as well as Eau Claire County and Arbor Place. And she probably sings at a local lounge on Friday nights too, I'm not sure. But she does a lot of different things. And so works in a lot of different places. So she is a prescriber for medication assisted treatment. So we're going to ask her to give us a little tutorial on that.
Hi, thanks for the invite on it. Like Chris said, I work a few different places doing mental health and addictions. So what I have today is a PowerPoint that I've used in other settings. So there might be a few slides that I push through. I don't know if I have a way to share the PowerPoint with you guys. Do you know, Chris? Can I do a share screen? I don't know if I can.
Krista, do we have the ability to share the screen with Kara?
Whoever is the host of the meeting.
Yep, I can just switch those settings, right?
Thank you.
It's all set to go.
It's one of those things I don't know if I have the capability on my end of hitting share screen and making this work at the same time, but I'll try it. If not, I'll just make sure I get a copy to you of the notes. If anyone wants them, I can have them. So I'll try it, but if it doesn't work, I'll try it the other way. I got to get back to where I'm at. Hang on a second. Okay, let me see if I can share screen here. Yeah, it's not going to let me. So for time's sake, I'll just talk. Yeah, I don't have the button, so I'll just talk, but I'll make sure I get a copy of the PowerPoint to Chris. If anyone wants it, then we can just email it out. Okay, so let me pull up my notes so I can talk. Okay, so what I was asked to talk on today is the medication-assisted treatment. MAT is basically a treatment that we use for opioid use disorders. A lot of people think about it in terms of being the medication part of it, but medications are really only a small part of it, or a part of it. We also do it in conjunction with behavior therapy, counseling, other supportive services. The opiates that we think of the most, obviously, in the area is heroin. We do also have prescription painkillers that are a problem. The medication that we use to normalize brain chemistry and to block the euphoric effects of the medications or alcohol, to relieve cravings and to normalize body functions without the negative or euphoric effects of the substance. Just as a little bit of a background, it's estimated that 2 million people have opiate disorders, making this a pretty significant issue, which is part of the reason why you guys are all meeting to figure out how to address this from jail recidivism rate and mental health combination. MAT's been proven to be effective, and it's really exciting for me to know that there's grants out there that are looking at how do we incorporate the jails into this to make it more successful for people on reentry and also to prevent that recidivism. The statistic-wise, within 3 months of release from custody, 75% of people who are in jail or prison with an opiate use disorder experience relapse, and those same people are 10 to 40 times more likely to die of an opiate overdose than the general population, often within the first few weeks of reentry. Medication-assisted treatment is evidence-based. We're using it in a lot of different settings. It's initially was only being used in clinic type settings or in treatment centers, but now we're starting to see things like this where we're using it in the criminal justice system, drug courts, reentry programs, and community corrections. There is, I don't know if you guys have access to this, but there are 2 SAMHSA guideline books that if you don't have them, I'd recommend them. You can go to the SAMHSA website and they are free to download. One of them is Principles of Community-Based Behavioral Health Services for Justice-Involved Individuals. And this was one of the reasons why I was going to share the PowerPoints, that if you need the links to it, it's in there. And then the other one is Medication-Assisted Treatment in the Criminal Justice System, Brief Guidance to the States. And a lot of these have a lot of this information that I'm sharing with you today is in these and talks about challenges, key considerations, and things like that. Treatment and rehab is considered ongoing. It includes identification of relapse triggers and preventive strategies and the delivery of primary medical care and behavioral counseling as a whole unit. Excuse me, treatment delivery systems, which is what I think Chris really wanted me to talk about today. A lot of people are interested in what is out there. People are aware of things like Suboxone, Methadone, Vivitrol, all of those type of things, but they really don't know what it entails. Excuse me. Again, just to reiterate this, medications are part of a whole treatment plan. We need to make sure that people are doing counseling and participating in any sort of social support programs. The first one I'll talk about is buprenorphine, which is Suboxone, or at least the one that most people know is Suboxone. It also is called Subutex or Zubsolv. There are different versions of it. They are what we call a partial mu opioid agonist. They have been available for more than 10 years. They're considered safer than full agonists, which will be methadone, which we'll talk about a little bit later, mainly because it has a ceiling effect, meaning that as we raise the level of buprenorphine that we're giving someone, its effects, including respiratory depression, increase, but only to a point, so that the more they take, we're not seeing what happens with regular opiates or heroin, which is where the overdoses are happening, where the higher you go, the more likely you are to have those adverse effects. Which also means that when we're using a medication like buprenorphine, Suboxone, Subutex, Zubsolv, that there's a lower risk of misuse, dependence, and side effects. Some risks do still, are still present, especially if used in conjunction with opiates. Occasionally, we do have people who are using Suboxone along with their street drug. Benzodiazepines or alcohol are also concerning to use with the buprenorphine. Buprenorphine or Subutex, Suboxone, Zubsolv can only be prescribed by a specially qualified practitioner that has to be SAMHSA certified. It used to be that these could only be done in intensive programs, but we're finding that more and more clinics are able to do this program if they're willing to set it up and do the waiver to have it. There's a lot of requirements to starting Suboxone. You have to do a lot of education with the client. You have to make sure they're appropriate for treatment, where they're at in their recovery. Some clinics do require that they're in counseling as well. Others do it from a safety standpoint of saying, we'd rather have you on this knowing that we have this ceiling effect and just keeping you safe. But typically when Suboxone is started, it started 24 to 36 hours from their last use. So they have to be in a little bit of a withdrawal state. This is considered the induction phase. Then we follow that up with a stabilization phase, which can take anywhere between a week and 3 weeks. Typically, it can take a little bit longer where the doses are getting a little bit adjusted. Most clinics like to see clients a little more regularly during this time while we're adjusting it. And then after that 3 to 4 week period, it does tend to stabilize out, and doses usually stay the same unless we find that people are in stressful situations, in situations where they're around other people that are using, falling away from therapy. And typically they'll come in and they'll say, I'm having more cravings. We kind of know that they're not working the program as much or being kind of bombarded by stressful things. There are some different thoughts on whether you increase the dosing or not. The rule of thumb typically by standards is to increase the dose to manage them because you're trying to prevent them from relapsing. And then people can stay in maintenance phase for a long time. There's different thoughts on this too. Some people feel that Suboxone or MAT therapy should be forever. There's other people that believe that this is a limited thing while you teach them the skills and get them into a different social setting where they're going to be more effectively managing themselves. We all know that the people that are in and out of jail, in and out of mental health crisis, tend to have problems with things like transportation, housing, finances, jobs, those type of things. A lot of times I find that as those things start happening where we're getting some stability there, that their doses of the buprenorphine can go down, and I have had some people be able to get off. Buprenorphine, Suboxone is the combination of buprenorphine and naloxone. Buprenorphine is the opiate, naloxone is the blocker. So basically what we're doing with those mu receptors in the brain is we're putting some opiates in there and some blockers in there. The brain thinks the blockers are like opiates. Subutex is just the opiate without the blocker, and then naloxone is just the blocker. Kind of similar to what we see in Narcan, which is what we use for reversing opiate overdose. I'm going to just mention methadone only because it's out there. I am not a prescriber for it. I don't use it a lot. It's a very strictly controlled medication. There's only certain providers that can use it. It's been out there for 40 years. It is considered the treatment of choice for pregnant opiate abusers. It's a little bit more difficult to manage. The bioavailability of it, it's a little bit different, and it is a straight opiate, meaning that it puts the opiate in there, but it doesn't put the blocker in there. It has a very long half-life. It takes 25 to 36 hours to get it to dosing, which means that if it's in there, it's going to take that long to get out of there. So when people say are incarcerated, when they've been put on methadone, it can take a good 3 to 4 days before you start seeing withdrawal symptoms. And withdrawal symptoms with methadone tend to be much more intense than they are with Suboxone. It's one that we typically, when they are put on it, they're tapered up very slow and tapered down very slow. Just to give you kind of a guideline, methadone typically can be dosed anywhere between 20 milligrams and 120 milligrams. I have seen it up to 160, 180. And when you are trying to titrate someone off of it, it's 2 milligrams every 1 to 2 weeks, which means it could take a year to 2 years to get someone off methadone. So that's kind of where the methadone tends to be a little bit longer treatment plan. It is good for certain heavy heroin users, but again, requires a very specific program and prescriber. Then naltrexone, when I talked about the Suboxone, having the buprenorphine and then naloxone. Naltrexone is kind of like naloxone, meaning that it's an agonist. It blocks the effects of the opiates or alcohol. And it's different from Suboxone or methadone, which activate the opioid receptors to suppress cravings, whereas naltrexone binds and blocks with the receptors. The nice thing about it is it doesn't require any special certification to prescribe or administer it. It can be done in any office setting. It can be done in the home. It doesn't require titrating or tapering. They do have to be free from opiates for 10 to 14 days. If you put someone on it before that time frame, you're going to put them into a precipitous withdrawal, which only has to happen once, and they're not going to want to do that again. There is no waiting period for alcohol. They can just start it right away. It blocks the euphoric effects and the feelings of intoxication. When we're using it for alcohol, a lot of times we're using it for harm reduction. You may find that they still will drink, but they can't get that high feeling. It's a little bit different when you're using it for opiates. The idea with opiates is you really don't want them to be challenging that because they can try to push past that and accidentally overdose. So there has to be a lot of really firm education of this is a blocker. There's no way you can challenge it and push past it. You're going to be at risk for overdose. Naltrexone does come in an oral form and an injectable form. The oral form is called Revia, or we just use naltrexone, and then the injectable version is Vivitrol. Vivitrol is an injection that's given every 3 to 4 weeks. We like it because we then know that they're on it. We don't have to have this, well, are they taking the pill? Are they not taking the pill? They tend to notice the blocking effects from the injection right away. Usually within a few days, they can say, yeah, the cravings are down. I don't have any desire to use. And then it's different for every person, whether it's going to last them 3 to 4 weeks. I have had a few people who can get out to 6 weeks as long as they're in a good program and not being activated as far as triggers. There's no abuse potential with naltrexone. I do have a few people who I have to be careful with it if they have active hepatitis or if they have alcoholism along with the opiates and have liver damage. We have to be a little bit careful with that because it can raise liver enzymes. Of course, when you're looking at the difference or the concern about is the naltrexone damaging the liver versus their drug use, their hepatitis, their alcohol, obviously we want the naltrexone on board, but that just means that we have to monitor labs more frequently. People can stay on naltrexone indefinitely. I have had a few people who have been on it for 3 to 4 years, but I find that the typical usage range is about 12 to 18 months as long as they're working a program. And then the last thing I'll just bring up, just because I think it's important, is naloxone, which is Narcan. And obviously anyone who's out there using opiates should have the Narcan available to them. And they can get that at any pharmacy. And then the HIV program in Eau Claire also offers it free of charge. So that is about all I have on the basics of it. But if anyone has any specific questions, I definitely am willing to answer that.
So this is Sarah. So I've got a question. So you talked about, if opiate use disorder and for alcohol use disorder. Is there any MAT out there for methamphetamines? That's what we primarily see in our community.
There's nothing. I think my video is locked up, so I apologize for that. But there's nothing that is FDA approved for methamphetamine or amphetamine use. We do have some off-label type things we use. There's been times that I do use Vyvanse, which is a stimulant. They have to be really, really screened carefully for that so that they're not abusing it. It'll be one of those things where they got to be in a treatment program or they have to be in drug treatment court, or I have to know that they're being monitored. Otherwise, some other off-label things would be some prescription medications such as Topamax or Baclofen that kind of help reduce cravings, or Wellbutrin that reduce cravings, but there's nothing that's FDA approved.
So Kara, I have a question. Do you know, this is Chris, do you know how MAT so my understanding is MAT for jail, you're looking at getting someone their first dose pre-release in enough time to let that be established in their system, and then the follow-up obviously when they're released. Is that your understanding as well? And what's the time frame to the dosing?
As far as being able to get on it when they leave jail, I mean, it'd be obviously ideal to get them on it within 24 hours before they leave. It doesn't always happen. Sometimes, or what we like to do is an naltrexone challenge, even just like a pill form, just to make sure that they're not going to have any adverse effects from it. But there's been times where we go, your risk, I'd rather you be a little bit sick than a little bit overdosed. And so sometimes we'll just do the injection without the pill challenge. But as long as they can get it within 24 to 48 hours before discharge, it's going to be active in their system for when they go. And then they just have to make sure they have a follow-up appointment set for that 3 to 4 weeks post-discharge or post-release so that they can get their next injection. Plus, that's their high-risk time. So they really should be seeing a provider that, 2, 3, 4 weeks out.
Immediately. And is there any advantage, or I mean, it does not sound like, but I just want to sort of ask the obvious. Is there any advantage to having someone start it earlier than that, like a month out or a longer period of time?
Not really, unless they've got Huber and there's concern that they're using when they're out, but most people won't use when they're out because they know that they're going to be tested and lose Huber. But you get a few that would be a risk. It's more of a cost thing unless you've got a grant to cover it, because Vivitrol is expensive. It's about $1,000. So pretty typically, if they're in a safe environment, we do, and we feel that they need something, we'll do the naltrexone tablets because those only cost about $20 until we get them ready for discharge. And then the main reason is using the injection because we know that they're on it and can't go home and just stop taking it.
Anybody
Alright.
else have questions for Kara?
Yeah.
Let's say
just have-
Mary.
Sorry. Kara, if you could, those two documents, the SAMHSA documents, I was trying to write them down and I wasn't quick enough. So if you could share those in the chat or send them through email, I'd appreciate that too. Thank you.
Yeah. I'll put them in the chat and then I'll also send them through, I'll give them to Chris because she's my easiest contact and she can get those out.
Thank you.
Kara, I don't know if you can speak to the what's covered with insurance or not as far as these drugs are concerned.
Yeah, as most people that are coming in and out of jail are on Medicaid, so I'm going to speak to that. Medicaid covers 100% for the naltrexone and for the Vivitrol. Suboxone they cover, Zubsolv they cover, Subutex, the one without the blocker in it, they only cover for pregnant women, but that makes sense because you really want that blocker in there to help prevent misuse. So they will cover it. Private insurances, it's the naltrexone and the Suboxone tend to be, well, naltrexone is easy, Suboxone hit and miss. We tend to have to go with a different generic version of it, but it's there. And then Vivitrol tends to be difficult just because if they are going, like, say, to a clinic that has to get the medication from a pharmacy, it's going to go through their pharmacy benefit, and then they're going to have that big copay that, you know, whatever their copay is for their prescription benefits. Whereas if they're going to a clinic that has it available at the clinic and they can bill it through their medical, then it's just billed whatever their medical office visit is. So that's where some grants come in handy to get this for people. And Vivitrol actually is a really good company to work for. They want to get the people in jail on it. So they do have some patient assistance programs also for people with trying to make sure they get on it and then help them get set up with a clinic in their community that can continue to give it to them.
Maybe I missed it, but how long does an injection last then?
Typically 3 to 4 weeks. The first few months I have found that they get it, like the first 3 or 4 months, they tend to need it every 3 to 4 weeks. A lot of clinics will go straight every 3 weeks until they hit that 4-month mark, and then they go to every 4 weeks. And then I have a few people that have been pretty stable on it and can push it out to 6 weeks as long as they're working a really good program and have been clean for a while.
Okay, thanks.
Any other questions for Kara? All right, sounds like not. Thanks, Kara. That was very, very helpful for our discussion.
You're welcome. And I'll let you guys talk, but I'll try to get those links to the SAMHSA in your comments.
Okay.
Okay, thank you.
Awesome, thanks. So I would suggest, Sarah and I were having a conversation about the agenda, and if you, I don't know if your agenda is in front of you, but our number 6 was to talk about the potential for to look at the interest that there might be, and I appreciate that the sheriff is here and he might, you know, not like be ready to commit or anything like that, but just to start the discussion about, is there interest or in moving forward with exploring what kind of hurdles there are to looking at MAT in jail. And I will just say that I was working this morning on a grant that Sarah and I are working on together that would potentially provide some funding for that as well. So I don't know, Sheriff, if you want to talk about, do you see this as something that's worth putting some energy into or not at this time, or not to put you on the spot?
Yeah, no, I certainly see some benefits. It's not going to be at taxpayers' expense, you know, because I don't have the budget for that. But
Right.
I'm not opposed to it, but we'd have to get our contracted medical provider on board as well, our jail doc and jail nurse.
One of the things that we talked about, Sarah and I talked about, would be that, you know, I'm not, so two options, you know, one would be, I'm not sure if your medical provider has the ability to administer it or not. I don't know that. I'm not saying that they do or they don't. I don't know that. But if they didn't, and outside of COVID, because we're currently in such a crazy time, but assuming that at some point in time we'll start to resolve, you know, the ability to have people go from jail to Arbor Place to get the medication, and then like some days before their release, so that it got started in their system, if it couldn't be as administered by the jail medical staff.
Yeah, I'd probably be more comfortable with somebody coming into the facility, unless they were already on work release or have the ability to leave the facility. Other ways, there's just an escape risk concern I have there.
And I'm not, it's not just, it's just the discussion, not the conclusion, but the difficulty would be that, like, for someone to come into the jail, what you're essentially doing then is expanding the practice from like Arbor Place or whatever, and then you have to get, you have to license a facility as a satellite office in order to do that. So
Sure. Well, and our medical provider works with all kinds of other jail facilities. So I don't know the ins and outs of their contract, but I'm sure they know it better than, you know, they're familiar with this and probably deal with it in other facilities. So
yeah, so they may well be able to be a prescriber and administer if there's the funding and to be able to do it.
right.
Yeah.
One thing I would want to mention too is, if I know release dates of people, the majority of them get on Badger Care within a week of their release, which would be paying for their Vivitrol if we get there.
Yes. Yeah. The point of financial coverage would be just for that first administration before they are potentially on another source of funding, or they don't have, you know, like they won't be eligible for Medicaid for whatever reason.
I think we're looking at a pretty limited scope of people who would be eligible or would qualify, or that this would apply to. I mean, we do have some heroin addicts that come and go from our jail, but like Sarah had mentioned, the drug of choice locally is methamphetamines. And
Yep.
If somebody comes up with a solution for that, they'll be millionaires. But so I think we're dealing with a pretty limited population here that this may benefit, but I'm certainly willing to take a look at it.
Awesome.
I'd just share anecdotally, we do have different people throughout the programs in the past that have taken MAT, and whether that was for opiate use disorders or alcohol use disorder, folks really responded positively, and as Kara indicated, it can reduce the cravings, and that really allows that cognitive behavioral therapy to start to soak in. I would just encourage the group to think beyond just the opiate use disorder too, to think about that alcohol use disorder, because that really, meth and alcohol are our two kind of main drivers as far as substances are concerned.
Yeah, if
And
you look
Sandy,
at Sandy's data.
Yeah, I can say she could probably speak to, you know, the data. She kind of meets with folks, but that anyway, the disclosure of the opiate use disorder is pretty low on the substance use abuse list. Sandy, am I speaking out of turn here?
Nope, you're right on point, Sarah. That's accurate with meth being first, followed by alcohol. It seems like the heroin, they reported in, I guess, in spurts. It seems like there'll be a stretch of time where we'll see a string of people where they're reporting heroin, and then it dwindles down, and then we'll have another spurt. But it's still by far meth and alcohol.
Well, and it's like a lot of other things that we've tackled. Our county is small enough and our numbers are small enough that no one thing that we do is going to be like, whoa, going to cure all things for all people. But if we can drain 1 to 10 people out of the system, it's 1 or 2, 10 or 10 people that we don't, we're not serving in the same way and are maybe benefiting from something that they wouldn't have previously benefited from. So you're right, Sheriff. I don't know that it's going to be a quadrillion people, even if we designed to look at opiates and alcohol, but every one that we do is somebody who potentially doesn't cycle back through, which is a savings for all of us as well as for their own well-being. All right. So would you be willing, Kevin, to do some exploration with or maybe that's with Heather, I don't know, but anyway, some exploration with your medical provider to see what the kind of where they're at with that? If they're doing it in other jails?
Yeah, I'll probably put that back on Heather and Brenda to work with them on and see where they're at with that.
Okay. Yeah, just to start the conversation at least. All right. So I'm going to circle back to staff report. Sarah?
Great. All right. So we've got first thing on the staff report is the sequential intercept model mapping. So we have concluded the 2-part workshop, about 9 hours in total. We had fairly good participation, about 30-ish or so folks participated. And then we were able to really look at our behavioral health, criminal justice system, identify some gaps, and then we were able to prioritize those gaps and then develop some action plans. And the 2 priority areas that stood out were affordable housing. That got 54% of the vote. And then the second priority area was the lack of centralized emergency drop-off or assessment crisis, the utilization of crisis beds, and then really the lack of step-down services and really the involvement it takes with law enforcement with that crisis system. So that one was kind of a mashed of several different things, but it really kind of focused on that crisis response and law enforcement's really lack of alternatives when somebody's in crisis. So that got 42% of the vote. So, and then there was a lot of other things that were identified, but with these 2 action areas, we were able to start during the workshop to develop an action plan. We haven't got the final report and the action plans back from our technical advisors on this, but they were going to really deliver the product that we were able to work through during the workshop, and then also their recommendations as far as things to consider as we move forward. So I know that Wendy was willing to really take up the priority area number 2. So I'd be happy if she'd want to speak to anything. And then for housing, we've kind of had Heidi Hooten as our point person, because this group's talked quite a bit about housing in the past. So I would just give an opportunity for Heidi or Wendy to chime in with anything that they'd like to at this point.
Sure, I can go. I did get a rough draft of the report. And I have a doodle pull out there just to get the first meeting scheduled for that second. And probably the coolest thing is that Chris found an article that Madison is actually doing something really similar, a lot more money. And they've been trying, I think I read it since like 2015 to have some sort of intermarry crisis option. And so it's really neat to see them doing it. I think it's something like $300,000 they're putting aside out of their budget for this resource. It's really, it just kind of neat timing to see that pop up right at the same time. I did send that with that email request yesterday for looking, yeah, $300,000 for mental health crisis center and alternative to jail. And I would reckon, wow, I talk so Northern, I would guess it's also a alternative to the hospital. So I think that gives me some hope as we go forth. And I think I reached out to Sheriff and just trying to get the last people and get that on the books here. That's the next step. I'm excited about it. Even if it's just data to, you know, the people, the powers that be, in hopes to have funding in the future or grants.
And do you know where the grant funding is, what the source is for Dane County?
Actually, I think it's right out of their budget. They're committed to providing 300,000 in the county budget. So
Okay,
it's, I don't know what part of the county budget, but I could look into that. That could be something we add to our goals or our you know, our focus of the group.
Well, and I would just say that, so in the last, well, so in the biennial budget, in the first biennial budget for Governor Evers, there was $15 million to create additional crisis beds in Eau Claire and Chippewa. And then that was vetoed. And then there was legislation brought back, and the some of the local legislators worked with hand in hand to think about, particularly, I know Senator Bernier from Chippewa worked hand in hand with the governor's office to address any concerns that there were about that legislation. And it was slated, it had gone through the Assembly Committee and been passed through them and approved, and then it had gone through or was moved out of Senate Committee and into slated for a Senate vote when COVID hit. So, but there was allegedly, at least, kind of agreement, shared agreement on the legislation passing. The difficulty is going to be because it wasn't voted on in the last legislative cycle. It's going to have to come back as brand new legislation, and that might create another whole process to that. But I think anything that we do to ferret out, continue to ferret out the impact on Dunn County will be helpful. Dunn County has spent close to $500,000 this year at Winnebago Mental Health Institute for folks who have been emergency detained there. Some people have had a longer term stay as well. But for people who've been placed there, and largely they go there because there isn't a local bed available. So it's not like we're not spending our own money to address the issues.
Right. Yeah.
So thank you to Wendy.
And just to be sure about the cost, there's nothing with juveniles, it's all adult costs, right?
It could be kids as well. I don't believe that we've had kids. Do you know, Wendy?
Santana would know probably right
Well,
off.
Santana would know. Have we had any kids at Winnebago?
Have we, like this year?
Yeah.
Yeah, we have.
Okay.
But they, MA covers.
Oh yeah, you're right. If they're you're right. Yeah, you're totally right. If they're under 22, under 22, then they MA will fund
Just
that.
the juvenile justice system overlap. So thank you.
Yeah. And we know that from some research, we have to do some updating with the counties. Well, we have to pull some data from the state that we're able to access to look at 2019. I might have done that already, actually, in this before the spring. But we know that the 17 counties in western Wisconsin have spent about $5 million in the last year just in placement. In the last spent $5 million in the last year on just placements at the Mental Health Institute. So,
Yeah.
which is a crappy place to have to go if you're in a mental health crisis.
Well, and I would say just on the crisis front, we've got some collaboration going with the Western counties about figuring out funding. So statutorily, County of Incidents is responsible for the first 72 hours. And we have a lot of people who travel outside of counties, and it's just like our folks travel to Eau Claire and they end up on a detention, those sort of things. So just there's been some administrative changes, and it used to be a gentleman's agreement that County of Residents would pick up that cost right away, and we've lost that. We've had, particularly in 2020, just an increase of it's the County of Residents needs to pay it, and then we push back, and I don't know that it's going to teeter totter, or it ends up being it evens out, but I think it's showing collaboration of the counties. So if we are able, when we make this project, when we work on this, I think we'll have the Western region support in saying, kind of to go off of what Chris is saying, we need this for the help of the jail and just decreasing hospitalization. I just think it's a need in our area.
Well, in law enforcement. So when we pulled some data together to advocate for the legislation, which didn't get through the process this last year, one of the things we did was a data analyst from St. Croix County pulled together average cost of law enforcement transport one trip, which we know that there's more than one trip often. Average cost from St. Croix County. And then what we did was we calculated that just as a start point, so it was applied uniformly across the region. We used that cost then and prorated it depending on mileage to the different counties. And I don't remember what the dollar amount came up to, but it's, it's certainly not insignificant, and it for law enforcement costs. And then I think, as Kevin has said, it's not necessarily it certainly isn't capturing all the costs, as it has just the inability, the data that we have has the inability to gather when you have to call in somebody else, or somebody's on overtime, or things that don't get done because somebody's driving across the state. I mean, just all those different pieces of the law enforcement response, which is critical as well, which is what has created push from the Sheriff's Association to try to address this issue as well.
I'll add one thing to all this too, that the cost to the families, if they have their loved one across the state, and you know how important that healthy family support is, and that hurts that too.
And we've had little kids sometimes.
Right.
We've had 8, 9, and 10-year-olds, which is crazy to think about. I mean, not that it's less traumatic when you're 20, 30, or 40, but I can't imagine being a little tiny child or the family of a tiny child.
Long time ago, I went on a pickup when I was a new clinician, and we went to Winnebago to pick up one of our clients, and I was inquiring, and they said the youngest kid that was there was 3, and I was like, holy moly. Yeah. So I agree, very far away from natural supports, hard to engage in follow-up resources. Yeah, there's all sorts of cost that isn't documented in numbers. I agree. So all the more reason that this would be helpful and beneficial, not just financially, but clinically, for sure.
And I think whatever we design will be unique to Dunn County. I don't know that we're going to be able to pick up a model. We're just not big enough to pick up a model and plop a crisis drop-off center in Dunn County. But I think that we can put our heads together and come up with something creative and expand what we've got available. And it's a bit of that. If you build it, they will come, because I think if we put together something, we will get interest from other counties as well around us, surrounding counties around us, to maybe either replicate what we do or utilize what we create. So
absolutely.
And I can't speak for our CJCC for Buffalo and Pepin County, but I suspect that we might be interested in partnering with you or supporting you, or at least learning about it, if it would be to your advantage.
Yeah, thanks.
Thank you. I would say, Chris, I'll just add, Sarah, before I've probably spoken too much. But we are, with Chris's support, Eau Claire County reached out to us to be able to start to utilize their crisis bed Midway, which only benefits Dunn County. They've had kind of it's only for Eau Claire County residents. So that will give us another resource in the crisis realm as well. It's not this project, but it is another option. So hopefully that will be able to be utilized sooner than later. So more to come on that.
Great, thanks for the update. Just wondering if Heidi wants to update on the housing side. I think there was a recent meeting with the Done Right Coalition.
Yeah, the steering committee met yesterday, and we have a housing action team meeting on Thursday. One good thing is we've been looking at doing a housing study, and one of our committee members went and talked with the city, and they're interested in partnering with us on that, but not this year because COVID is taking precedence. But that's a promising thing. And then next we'd have to approach the county on that, so see if they would partner with us as well in some outlying areas. But so that's a positive thing. Housing is so huge, and it really takes the city and the county to partner with us, because you know, otherwise getting permanent housing, you have to attract some of that, and it's just a really huge, I don't know, it's kind of overwhelming. The other thing that we need to that we'll be discussing on Thursday is some more practical emergency type solutions. We're going to brainstorm on that because we have a lot of folks who are homeless, and we've got to find a way to kind of transition between being homeless and getting into permanent housing. So, and we're working on a new landlord list. I did get a list of all the landlords in Menominee from the city. So we're working on expanding that again and reaching out to landlords and doing some of that kind of work too.
All right, great. Thank you, Heidi. Okay, real briefly, since we're running low on time, reentry program update. So we've had some changes. So if Heather and Jackie, if you guys want to kind of talk about how the reentry program's kind of gotten I guess rejuvenated a little bit from COVID. Things really slowed down, but then we were having some meetings to kind of get things back up and running and get access to folks. So if you guys want to speak to that.
So earlier this month on the 14th, we started taking people back into reentry project where I'm facilitating, and I got Jackie on Zoom to do the orientation along with me. And we've gained quite a few participants because there's a lack of time between when that happened and the previous time. So a lot of people are eligible. And then we had this week, because we do it the second and fourth weeks of the month, we had 2 additional people come to orientation. So and then another adjustment that we've made, sorry if there's a lot of background noise, is Jackie's been visiting with people through the video visitation system to make some of those connections with individuals while they're here during this time.
Yeah, so I can just add that as of next week, we're going to be changing to the remote option rather than going to the facility for the video visitations, and it's about risk with folks not wearing masks in the lobby and the visitation rooms themselves. Overall, I mean, some are, but yeah. So so that'll start next week, And, you know, it'll have to, because it's using the reentry money, the funding, for those who are truly engaging or on the verge of it, the visits will be more frequent. And for those who are kind of just sideliners, they won't be as frequent. And I will have conversations about folks, so it's not, so, you know, it's their choice. It's their choice. But that's it.
Okay. Thank you, both to Heather and Jackie there. CIT update. So we partner with Eau Claire PD for that crisis intervention training for law enforcement. Typically that's in September. As we kind of anticipated that Eau Claire was not moving forward with the CIT this year. So that is the case. So really no local options. That's where we have Lindsay Field that helps kind of facilitate and supports the training, and in exchange we get 5 seats in that class. So for 2020 there's no class. We'll hope for a better 2021, so we can get create those opportunities for our newer law enforcement or those that haven't been able to do that in the past. And then looking at the first aid, mental health first aid update. So Arbor Place, the partnership side, the Dunn County Partnership for Youth, is doing some virtual mental health first aid. They're just trying those out right now to work out the kinks, but those will be available free and really on virtual platforms. And they can also do closed group sessions. So when we were kind of talking last month about potential correctional officer training, the Arbor Place could do specific training just for correctional officers or any closed group that makes sense. So they're open and available to do that. So as we talk more in the future about those correctional officer trainings, just know that that's an option. Sounds like it'll be a little less intensive in the time format. That's why they wanted to have staff to go through that training to make sure they really work out the kinks. As we know, kind of moving our work to these virtual platforms, there are it does change work and how we relate to each other. So they just wanted to make sure it was going to be a good training in that virtual format. And then the last thing for staff report, the jail booking screening update. So that's something that we've had, we talked last month, that it is on our list for goals. But at this point, I think the conversation really talks about, you know, some of the difficulties in doing that. So I guess the recommendation here is that maybe we just focus on other priority areas versus that kind of implementing that booking at the correctional officer stage. We do have Sandy's assessment protocol in place. So just kind of a recommendation that we continue to run into some roadblocks with that, and then really looking at the big intent of it. You know, it's not just to get prevalence, it would also be to connect services. And if we're just really not able to move on that right now, I think we've got other areas that we have consensus and have the ability to move as we discussed at our last meeting. So that's the staff report, unless there's questions.
So basically we would be putting jail booking screening to rest for a while, if not permanently.
Yes.
Okay. All right. Well, we are out of time. Sarah and I have another noon meeting. I just wanted to finish by talking just for a moment about like one of the one of the pros that I see to the work that we've done, and it happens to involve the police department, although it could just as easily be the sheriff's department. But we have an individual who's being served in our county in a number of different ways through our agency, who is very, very paranoid right now and threatening. And some question of this individual's potentially being setting themselves up for a suicide by cop. And we've just done, I think, because of all the conversations, the relationships, the understanding of mental health, there's just been a really nice, consistent response around continually assessing what's going on, not overreacting, hopefully not underreacting, and keeping all the parties in open communication and trying to continue to assess what's the best avenue of intervention for this individual. And I just don't know, this would not have happened 10 years ago. Not because people weren't good-hearted and wanted to do the right thing, but we just would not have had the tools to be able to pull it off, I think, in the same way that we're able to now. And so I think it just reminds me of the work that we're doing and the importance of that, and not only protecting this individual who has a severe mental health issue at present, but also the people that intervene are poised to intervene, and trying to keep them safe as well. So it doesn't mean that it will end well or it won't end well, but I think that we're doing things differently than we've maybe ever done them, and it's evident in this particular case. So it's just some encouragement for us to keep on. And with that, I think we will be done, and we will resume next month on the 27th of October.